let's discuss how the use of echocardiography in the intensive care can really help influence your management of hemodynamic instability with patients with coronavirus 19. My name is John Aaron. I'm a consultant at St George's Hospital in the intensive care unit. So let me tell you a story, and it's based on our experience at St George's Hospital managing nearly 200 patients with coronavirus. Your story, I'm sure, is similar to ours. Lots of patients came in with hypoxia and chest x-rays looking a little bit like this. And soon, one patient became 2, then became 3, and before you know it, you're overwhelmed with numbers of cases and you're opening up new intensive care units. And actually, from an individual patient perspective, the x-ray got worse and worse and worse. And it became like a horror story that despite your best treatment, things that we knew to be right, things were getting worse, not better. And one patient turned into 2, turned into 3, turned into 4, and so on and so forth. I think it's important to take a step back and think about that patient before you met them as they got wheeled through the doors of your intensive care unit. So let's go back in time. And their disease started 2 weeks ago. They were sick with cough and fever, maybe for days before coming into hospital, where they received lots of oxygen therapy, and then their oxygen therapy got escalated to devices with higher flows, and then eventually with adding in some extra pressure, and then when all that failed, they got intubated. So the point is, their disease was potentially going on for days, maybe even weeks before you ever met them. So, is it really surprising that as soon as everyone got onto a ventilator, they needed some vasopressor therapy? Well, we get our old medical textbook, dust it off, open it up, and these are the differentials of shock, which by definition you are if you require noradrenaline or vasopressin. So there's hypovolemia, there's distributive, there's spinal, there's obstructive, and there's cardiogenic. And I think initially it was very easy to justify why everyone required noradrenaline. Hypovolemia and dehydration was probably an under-recognized feature. And I'll talk about a little bit more about that in a moment. These patients were sick for days before they arrived in the intensive care unit. And whilst in hospital, probably a negative or at least neutral fluid balance was actually a sought after thing by doctors and nurses looking after this cohort of patients, because that's what we were taught was the right thing to do. Now, these patients were definitely hyperinflammatory with high temperatures, and vascular tone was clearly reduced in these patients. And in addition, they required very high sedation. Propofol in particular was used in the initial phase of the disease, and this, as you know, has very significant effects of inotropy and vascular tone. So we know that keeping these patients dry is good, right? It was permeated throughout our literature for the last 20 years when dealing with acute respiratory distress syndrome. And this is something that we know, and as I said, we practice now pretty routinely. But hang on a second. It was never a trial in dry versus liberal. It was a trial in conservative versus liberal. So a neutral fluid balance at day 7. And this was after a period of initial resuscitation occurred. So actually, by artificially chasing a very negative fluid balance on top of someone who has been sick for some days, therefore have reduced intake, and has been hyperprexial and therefore has high insensible losses, and has received high flow oxygen through various devices, compounding fluid loss from the respiratory tract, then actually there's a good chance these patients were overly dehydrated, which, as we know, is a contributing fact to AKI, but also thromboembolic disease, both of which we saw quite prominently in the early phases of the disease. So when you put an echo probe on these patients, this is a very typical study that you may see. So it's a relatively hyperdynamic heart. These hearts are tachycardic, but otherwise look pretty normal. So both left and right ventricles are hyperdynamic, and the chambers are normal size or even potentially small. Now, if there was any tricuspid regurgitation in the early phase, the TRV max was raised somewhere between 2 and 3 meters per second. But I suppose in the context of being so hyperdynamic, this is very difficult to interpret and may actually not represent pulmonary hypertension at all. And then if you look at the left side of the heart, and the first slide here, we have the mitral inflow tract. So we have an E wave, which is very high, it's a meter per second. We also have the tissue Doppler, the mitral annulus, and here we have a hyperdynamic E prime and a hyperdynamic S prime. And we have flow out of the left ventricular outflow tract, which varies with respiration. And here there's a 30% variation. So all of these things, a high E wave velocity, a hyperdynamic tissue movement, and a variation in your flow out of the heart would identify a fluid responsive state. And indeed, in such a patient, if you were to give a fluid bolus, your LVOT VTI, which is a measure of your stroke volume out of the left ventricular outflow tract, would go up. And in this case, it's gone up from 18 to 23.2 with one fluid bolus. So a very significant increase indeed. But hang on a second. Let's go back and have a look. On every single scan after the first few days, the right ventricle looks moderately dilated. And we've already talked about how the TRV max is also mildly elevated. So what's the explanation? And I think to answer that, we've got to take a step back and think about our pathophysiology. What happens to the heart when the patient has sepsis? Let's take systemic sepsis, like gram-negative sepsis as a result of a renal tract infection. What happens there? Well, you typically get a very high cardiac output state with vasodilation, so reduced afterload, and therefore the left ventricle looks hyperdynamic. And that is in part because the afterload is very low. So it doesn't matter how much you fill the left ventricle, because there is no resistance to flow. When the ventricle contracts, it empties completely. Okay, so it by definition results in a hyperdynamic left ventricle. Now, in a way, if the left ventricle is struggling at this early stage, you wouldn't see it because it's not having to work hard. Even if the left ventricle was impaired, because it's only having to overcome very, very low resistance, it still looks hyperdynamic. But as soon as you correct that afterload with some noradrenaline, for instance, and optimize the preload with fluid, suddenly the left ventricle, which once early on looked fine, suddenly isn't, that it's actually struggling a little bit. And suddenly the left ventricle doesn't look quite as good. And we see this quite often. A day or two after they come to ICU, and you correct the afterload and you correct the preload and you re-echo them, and actually the left ventricle now suddenly looks impaired. Now, what about the right ventricle? So the same thing must occur with the right ventricle, but the right ventricle is different for a couple of reasons. First of all, it's got much less muscle. Therefore, actually, it produces less force. But that's okay, because it doesn't have to overcome nearly as much afterload, because the pulmonary circulation normally has a very low afterload compared to the systemic circulation. And in sepsis, the pulmonary circulation is affected as well. So there's low pulmonary vascular resistance, meaning the right ventricle looks hyperdynamic as well. But in coronavirus patients, your pulmonary vascular resistance increases. So you get hypoxic vasoconstriction and parenchymal disease, which then result in a very early either normalization of the pulmonary vascular resistance or an increase in your pulmonary vascular resistance. And therefore, if the right side of the heart becomes impaired, this becomes apparent very early, and it may become apparent as a dilated RV. So, these are several different patients from our cohort. The right ventricle looks at least moderately dilated, but by most measures, function is relatively normal, at least in the early phase. And you can measure the function by a number of different ways. The most commonly used and simplest is the TAPSE measurement, and here we have a case of 2.7 centimeters, which is obviously very hyperdynamic. You can measure the RVS prime, which is a tissue Doppler of the right ventricle, and here in this case it's 0.21 meters per second. The fractional area change, which is like the ejection fraction, but for the right ventricle, and in this case it's very exaggerated. And you can look at global longitudinal strain as well. And whatever measurements you look at, the right ventricle early on appears to be functioning well but dilated. And the TRV max is also constantly raised between 2 and 3 meters per second. And it's not clear what that means. So, what do you do with this information? I think it's important to understand what you're seeing. So the right ventricle has to generate force. The resistance the right ventricle is pumping against is due to a number of factors. Your ventilator management and how much PEEP you've set up and what your mean airway pressure is as a result, the hypoxic vasoconstriction that's clearly going on, and worsening parenchymal disease as your ARDS develops into more classical type. And then, of course, you get microemboli formation, and that could be because of a number of reasons. Obviously, the patient is hyperinflammatory, and that's a predisposition to developing clots, but also severe dehydration can also predispose to that as well. And the flow through the pulmonary circulation is as a result of the force generated by the right ventricle and the resistance it has to pump against. All of these factors here, all in the early phase, may actually normalize pulmonary vascular resistance, because remember, in a hyperinflammatory state such as sepsis, your pulmonary vascular resistance should be low. But the fact is, all of these things normalize it, and then, as they get worse, increase it. But the right ventricle has decompensated because of a direct effect on its myocardium, and therefore dilates up early, and even though it looks hyperdynamic, it's probably not right. It's probably not hyperdynamic enough. So, the greatest teacher failure is, and actually despite your best management of these patients, moderate dilation with preserved function progresses to an increasing dilated RV, and your TRV max may creep to 3 meters per second or even higher as the lung disease worsens. And then you start getting first a normalization in your systolic function. But I stress that normal systolic function in this context is abnormal. The whole circulation is hyperdynamic. So the fact that things are normal means they are actually impaired. And then eventually you get severe dilation with pressure effects on the left ventricle and a reduction in your systolic function. And then at some point along this, you get a pulmonary embolism. And how to differentiate between the last point and the second to last point is actually very difficult, sadly. And here we have a case, a patient with coronavirus, and you can see quite early on that the right ventricle is severely dilated, and actually even eyeballing the function, it looks reduced. But in context, look at the left ventricle. The left ventricle is hyperdynamic, so the right ventricle should be as well. So the fact that the function measures as normal is abnormal. The TRV max is between 2 and 3. In this case, it's creeping towards 3 meters per second. The TAPSE is now borderline at 1.7 centimeters. Your RVS prime is now borderline, and your pulmonary valve acceleration time is also short. So this implies worsening pulmonary hypertension and a reduction in your systolic activity of the right ventricle. But if you look at the left ventricle, your E-wave velocities are still very high, above 1 meters per second. Your tissue Doppler is still also very high, and the left ventricle looks hyperdynamic. So in isolation, you'd want to treat the left ventricle with further volume expansion. But obviously, with that kind of RV, further volume expansion is actually relatively contraindicated. So you're getting a bit stuck for what to do. So what do you do? Well, there's a few things you can try. You can play a bit with the PEEP. You can try perhaps increasing your mean arterial pressure with vasopressors to try and improve right ventricular perfusion pressure and therefore maybe squeeze out a bit more force generation. You can potentially switch to vasopressin, and vasopressin may increase your pulmonary vascular resistance less than the equivalent dose of noradrenaline, potentially. You can add in the ninotrope, which will try and increase your right ventricular force generation. But actually, that's a very difficult thing to do when your left ventricle looks so empty and hyperdynamic. It's quite risky. You can diurese to try and offload the right ventricle. But again, the left ventricle looks empty. So that's again a dangerous thing to do. You can try and prone if there is significant lung consolidation. And that may recruit areas of the lung and therefore reduce your pulmonary vascular pressure. And then there's drugs that target pulmonary vascular tone directly, such as inhaled, IV or oral options. And then if you think there's a good chance that there's thromboembolic disease which is contributory to this, you can then thrombolize. So firstly, let's talk about PEEP titration. So I think most people would have dealt with this patient cohort as ARDS. And as part of that, there is the PEEP ladder, where the more oxygen you dial up, the more PEEP the patient needs to maintain recruitment. Now, a unique feature of coronavirus ARDS is that the compliance early on is actually very well maintained, and therefore high PEEP could actually result in high pulmonary vascular resistance. As a result, you're simply overdistending the alveoli and compressing the pulmonary vasculature. So reducing PEEP, lifting that elephant off the patient's chest, may actually reduce your pulmonary vascular resistance and therefore reduce the strain on the RV. And this is such an example where a patient ended up very hypoxic with a very high PEEP overnight, and just by bringing the PEEP from 15 down to 8, you can see the effect on the right ventricle. And actually, as a result, the oxygen requirement came down from 80% down to 55%, and the patient's hemodynamics improved dramatically. So this is a case of overdistension, and you can see how the RV reduces as you reduce the PEEP. But if you consider the right ventricle as the camel in this picture, it doesn't just fall over because of one factor in this disease. It falls over because of multiple different straws. So the vasopressor, high vasopressor therapy, the hypercarbia, your hypoxia, the PEEP you've dialed up, developing parenchymal disease, and PEs may actually be the straw that broke the camel's back. Now, they may not be big PEs, they may be multiple small PEs, but in combination with everything else that's going on, the RV is then unable to cope. And remember, the RV is not itself. It has its own impairment, it has its own impaired myocardium because of a whole host of different things. So a small PE could be the straw that breaks the camel's back, not necessarily a big PE. And in this case, a patient we were looking after deteriorated quite suddenly, required a lot more noradrenaline to maintain their blood pressure, and this was their echo. And this was a very significant change from their prior echo 2 days ago, and you can see that this is clearly a very, very enlarged right ventricle, and importantly here, it's actually compressing the left ventricular outflow tract, and you can see how small this left ventricular cavity is as a result of pressure. So it's not the kind of thing that fluid would fix. In fact, fluid may make this worse. It may dilate the right ventricle even further, causing more compression of the left ventricle. So this is the kind of patient that suddenly develops PEA arrest and therefore is unretrievable. And here, very, very clearly dilated RV. And you can see the RV systolic function is non-existent. There is no fractional area change of that right ventricle to speak of. The TRV max here, as you can see, is still between 2 and 3 meters per second. So not that much changed. But here, what's quite interesting, if this is the flow out of the left ventricular outflow tract, you can see that, so this is impending left ventricular outflow tract obstruction, where you get a very slow rising pressure gradient with perhaps an interruption in the mid-systole. And here, very nice demonstration of McConnell's sign. And the IVC is fixed and does not vary with ventilation. So all of these things are pretty consistent with a PE. Now, they would be consistent with a massive PE, but in this case, it may not be a massive PE. It may be a small PE plus everything else that's going on. Now, it's easier to make a decision if you can see a clot. And in this case, there was a right ventricular thrombus here, which 2 days after thrombolysis was no longer visible. And you can see actually quite nicely that the right ventricle has got smaller and the function has improved quite dramatically by thrombolysis. And in this case, of course, we can see here another patient with a dilated RV, reduced systolic function in the right context, and a very, very nicely seen saddle embolus here on transthoracic echo. Very nicely seen. And again, the TRV max is at 3 meters per second. And in some cases, thrombolizing a patient does actually help. This is a patient who had an echo before thrombolysis. The NORAD is at this time 0.25, but got to 0.4 before we acted. You can see the RV is dilated. The size is greater than the left ventricle. TRV max, it's at 3.5 meters per second in this case. The IVC is fixed and dilated. and your tissue Doppler of the RV is reduced. And after thrombolysis, your TRV max hasn't really changed because the underlying lung condition hasn't changed, but your S prime is now greater, your TAPSE is now greater, your IVC now shows some variation. And you can just see the eyeballing. The right ventricle is now functioning much better, it looks a lot freer, and perhaps it's got smaller as well. But most importantly, the noradrenaline is down to 0.04. So a big difference for this patient. This patient survived. So even though RV is a big feature for many patients, there isn't to say that this disease doesn't actually cause LV dysfunction as well. And there's a spectrum of disease. So you can get a direct myocarditis secondary to COVID, and we're not quite sure of the incidence of this, difficult to say. We think it's pretty rare. Probably much more commonly seen when you see left ventricular dysfunction is as a result of the systemic inflammatory response, or as a result of a sympathetic overdrive, so either adrenergic or septic cardiomyopathies. And don't forget that very high dose of sedation could actually contribute quite significantly to negative inotropy. There's existing heart disease, and we know that patients with hypertension and diabetes and existing heart disease are more susceptible to the severe forms of coronavirus. And don't forget to look for all the usual causes of an acutely impaired left ventricle, such as actual MI. So this is a case, a young chap in his 40s who suddenly developed a very high noradrenaline requirement, and when we echoed him, he had a globally impaired left ventricle. It's not dilated, and the shape is maintained, so it still looks like a bullet, and the left atrium in particular is still quite small. So all of these things, even just eyeballing it, would identify this as an acute situation rather than anything chronic, where some of the compensatory mechanisms would become apparent. And again, if you look at the mitral inflow, the E wave is normal at 0.6, and the E over A is normal. But if you look at the VTI, the flow out of the left ventricle, then that's severely impaired at 9.4 centimeters. So this is completely out of keeping. And actually, in this case, you can use echo to titrate your therapy, which in our case was dobutamine, and you can make sure you get the right dose of dobutamine. So the first picture here is 2.5 of dobutamine, and you can see the VTI has gone up to 11.5. The second slide is 5 of dobutamine, and the VTI has increased to 13.7. The third slide here, the dobutamine is now on 7.5, and our VTI is up to 14.7. And here it's at 10, dobutamine on 10, and the VTI is up to 16. Going to 15 mics per kilo per minute actually caused a reduction in the VTI, so that's when we tailed it back. So using echo, we found the optimum dose of inotrope. And actually you can see this at the short axis view. You can see how the left ventricle picked up during this time. And actually, eventually this patient went for ECMO, and when they came back, the left ventricle had demonstrated some recovery. So ejection fraction is still not normal, maybe in the region of 35 to 40%, but much better than the 10% that it was to start with. Now this patient, again, similar story. Their noradrenaline suddenly shot up, day 3 of admission to 0.3. And in this case, it's slightly different. So you can see here that the right ventricle actually looks okay. But here the apex looks a bit dilated, and you can see that the apex really isn't moving. Yeah. If you look at this image, the apex is completely akinetic, and even here at the mid portion of the ventricle, not really doing anything. The base seems to be still going up and down, and there's still some contraction here at the basal level. Now, so this looks like a stress cardiomyopathy, an adrenergic cardiomyopathy affecting the apex and the mid portions of the left ventricle, which is the typical pattern. Now, how do you differentiate this, an acute adrenergic cardiomyopathy, from something that's chronic? Well, it's difficult, but there's no dilation of the left ventricle that would maybe be seen with this degree of impairment if it was a chronic condition. And again, the mitral inflow is relatively normal. And E wave velocity is normal, E over A pattern is normal, so that's suggesting something, an acute state. And again, 2 weeks later with supportive treatment, the left ventricle looks pretty much back to normal. Now this lady, she kept nearly arresting every time she was proned, and eventually we did an echo on her, And this is what we discovered. So she was clearly a hypertensive diabetic lady, and the reason that she kept arresting every time we tried to prone her was because she had this very prominent hypertrophied heart, in particular this septal knuckle. You can see here this turbulent flow through the left ventricular outflow tract, and you can see here this anatomical obstruction. This is continuous wave Doppler through the left ventricular outflow tract, and the velocities here are 3.5 meters per second. So that's very, very raised. And every time we proned her, we presumably reduced her preload further by obstructing her IVC flow, and this caused a left ventricular outflow tract obstruction. A note about obstructive shock. High PEEP or APRV in certain individuals can actually cause acute cor pulmonale, mimicking a PE. A pneumothorax, hemothorax, and pneumomediastinums can all cause it as well. And this is a case where a patient was very, very shocked and unwell, and when we echoed them, we not only found this big black thing obstructing the left ventricle, the big black thing was actually an expanding hemothorax, which was occurring after the patient, which was deemed to be high risk of thromboembolic disease, was on a very high dose of heparin. So, suddenly your differential diagnosis of shock becomes a lot more complicated. Differentiating hypovolemia and a hyperdynamic state is actually quite difficult. Distributive shock could also be hypovolemia, and the question is whether this is going to be vasopressor responsive, what the right dose is, and if you give too much vasopressor, you can actually increase resistance and impair your left ventricle further, or your right ventricle. Now, cardiogenic is obviously not just one thing. It could be a cardiomyopathy, and it could affect the RV or the LV or both. There could be an RV pressure overloaded system. There could be left ventricular dysfunction, which could be global, and the etiology of that is numerous, or it could be regional. And there could be all kinds of interactions with their existing chronic heart disease. And obstructive shock, small PEs, which contribute to the rest of the picture going on, or big PE, ARDS, PEEP, vasopressors, tension, and all of the above are likely. Luckily, we don't have to think about spinal shock in this cohort. And then when you think about all these things, the interventions are numerous. Fluid, noradrenaline, steroids, inotropes, vasodilatory therapy, ECMO, beta blockers, revascularization, thrombolysis, ventilator manipulation, or a chest drain. And if you think about an exam question that asks this, in a patient with coronavirus 19 pneumonitis, with cardiovascular instability, what is the best treatment to treat their shock? And if these are your options, this question becomes impossible. And the only way to answer this question is to, firstly, understand the disease. Secondly, understand the pathophysiology. Thirdly, understand what the treatment options can achieve and in what context. And fourthly, be able to make the diagnosis, which requires the person with all those other steps doing an echo themselves. And just to say that pre-existing cardiovascular disease is clearly a factor for a worse outcome in coronavirus patients, and in almost all the studies, having coronary artery disease or cerebrovascular disease or any kind of cardiovascular disease worsens your outcome. And acute cardiac injury is very common, as defined by cardiac biomarkers. But again, this is a bit simplistic. As we've described, acute cardiac injury could be the right ventricle, could be the left ventricle, could be both ventricles, could be a global phenomenon, could be a regional phenomenon, and doesn't actually give you an idea of how to treat that. And of course, cardiac injury, and if it was there, then your outcome was worse. So, how does echo help the clinician treating this patient? It allows you to diagnose the cause of shock, because it's almost certainly multifactorial. And it's not just you've got to diagnose it, you've got to work out what's the predominant thing that you can treat. And protocolized management of this cohort is very difficult because the balance between these different factors are often completely individual and therefore need individualization of their treatment strategy. It allows you to titrate fluid therapy, vasopressor therapy, inotropes, even your sedation and your PEEP, and allows you to monitor for progress, for response to treatment, and determining whether something was successful or failing. It allows you to initiate new therapies, like decide when to prone, when to start pulmonary vasodilator therapy, when to thrombolyze, or when to refer for ECMO. So, the greatest teacher failure is, and we have learned a lot because our current management strategies didn't serve this patient cohort well. And the whole point is you must bring balance to the force. And the force in this case is the force generated by the right ventricle versus the resistance it has to pump against. And when you figure out how to do that successfully, you've got to pass on what you've learned, which is why webinars such as this one are so important. And Yoda said it very well, and clearly he was able to do echocardiography and understood the condition very well. A chosen one shall come, and through them will ultimately balance in the force be restored. And that is the whole point of how to manage this condition. I'd like to say thank you to the POCUS team at St George's, who did a lot of hard work during this difficult time, and they were amazing, and they have learnt a lot, as have I. And if there's any questions, please feel free to email me at the email address below. Thank you very much.